Welcome to Kanski lecture series, and this is going to be the Cornea part 15. So in this chapter in this part we will discuss about the miscellaneous keratopathies. That is a different type of keratopathies that are not so common but still present, and you should know about that. So one is a infectious crystalline keratopathy. So infectious crystalline keratopathy, one thing you have to remember about the infectious crystalline keratopathy is that it is caused by the virus streptococcus viridans, and also it is very common post PKP after the use of the steroid. So if you remember these two things, I think you're done with the infectious crystalline keratopathy. Infectious crystalline keratopathy is a rare indolent infection usually occurring in a patient on a long-term topical steroid therapy with an associated epithelial defect, most frequently following a penetrating keratoplasty. Streptococcus viridans is the most commonly isolated, although numerous other bacteria and fungi have been implicated. So these are the things I have told you earlier. Slowly progressive gray-white branching stromal opacities are seen associated with minimal inflammation and usually intact overlying epithelium. So figure 7.37. So you can see the branching pattern. You can see you can see the crystalline pattern. So overlying epithelium is intact and there is a stromal opacification in a branch-like pattern. And you can see that there is a crystalline keratopathy in a patient of a graft. A biofilm is present that allow the survival of the organism, reduce antibiotic bioavailability, and make diagnostic detection difficult. Culture or biopsy is performed to determine the organism and topical antibiotic instilled for several weeks. Adjunctive therapies to enhance the efficacy of treatment include disruption of the microorganism biofilm by laser, intrastomal antibiotics, and keratectomy. In case that do not respond to treatment or where the corneal scarring is present, corneal transplantation is required. So basically, in the case of crystalline keratopathy, there is a biofilm that is formed, and because of this, that makes the um, topical treatment very resistant. So for that purpose, what we do, we can inject intrastromal antibiotics, and we can also do keratectomy. But if all of these procedure fails, then penetrating keratoplasty is the procedure of the choice. Now next is a thigh-gazing superficial punctate keratitis. So basically it is a coarse like granular like opacities that are present, and that is a superficial. So these are thigh-gazing superficial punctate keratitis. Thigh-gazing superficial punctate keratitis is an uncommon idiopathic, usually bilateral condition characterized by exacerbation and remission. It is commonly of onset in young child adulthood but can affect patient of any age and may recur over decades. So it presents in the young adult. So diagnosis consists of recurrent attacks of irritation, photophobia, blurred vision, and watering. As with any keratopathy, there will be the blurred vision, there will be the photophobia, there will be the reclamation and watering. So what are the signs? Signs of the granular coarse raised slightly elevated grayish epithelial lesion that stain with fluorescent may involve the central cornea. A mild subepithelial haze may be present, especially if topical antiviral have been used and there is little or no conjunctival hyperemia. So you can see the figure 7.38. So 7.38, so you can see thigh-gazing superficial punctate keratitis. So these are multiple coarse granular opacities that is present in the cornea and it is central. Differential diagnoses include post-adenoviral keratitis. So what are the treatment? Topical lubricants may suffice in wild cases. Steroid and low potency preparation is used twice daily, initially with gradual tapering to as little as once weekly instillation. High intensity treatment may sometimes be needed initially. Cyclosporin 0.05% is generally used if the response to the steroid is inadequate or as an alternative in longer term therapy. However, some authorities recommend cyclosporin for initial treatment. Tacrolimus may also be ineffective. Antivirals have not been found to be consistently helpful. So, topical treatment is basically topical lubricants, but we can also give mild steroid for the some time period to reduce this. Contact lens wear is a extended wear or daily disposable soft may be considered if steroids are ineffective or contraindicated as an alternative to cyclosporin. Phototherapeutic keratectomy brings short-term relief, but recurrence is likely. So recurrence is common in case of Tyson superficial punctate keratitis. Next is a filamentary keratopathy. So basically, the filamentary keratopathy is anything which cause the filaments to be present. So what are the filaments? So basically, this is the mucus that is attached to one end is attached to the epithelium. So these are very loose, but they do not detach. So these are the filamentary keratopathy. It is most time of the time it is occurring in a cases of the when there is a dry eye or there is an autoimmune disorders. Filamentary keratopathy introduction. Filamentary keratopathy is a common condition that can cause considerable discomfort. It is thought that a loose area of epithelium acts as a focus for deposition of mucus and cellular debris. The causes are shown as table 7.6. So you can see the 7.6 causes of filamentary keratopathy: aqueous deficiency, keratoconjunctivitis sicca, which is also known as dry eye; excessive contact lens wear, which can also cause dry eye; corneal epithelial instability, recurrent erosion syndrome, corneal graft, cataract surgery, refractive surgery, and drug toxicity. So all of these can cause dry eye. So that is why it cause filamentary keratopathy. Superior limbic keratoconjunctivitis, bullous keratopathy, neurotrophic keratopathy, and prolonged or frequent eye closure. So these are, you have to remember this. So, how do you diagnose it? Diagnosis is symptoms consist of discomfort with foreign body sensation, redness, and sometimes photophobia. Signs are the strands of the degenerated epithelial cells and mucus that move with blinking and are typically attached to cornea at one end. Filaments stain well with rose bengal and to a lesser extent with fluorescein. A small epithelial defect may be present at the base of the filament. Corneal filament may form Chronic filaments may form plaques. So you can see figure 7.39. So you can see 7.39. So you can see that there is some kind of mucus that is attached to the epithelium. They move with the blink, but they are usually attached and they do not become detached. You have to pick them up and manually remove them sometimes. 7.39 corneal filament, comma shaped lesion attached to the cornea at one end, be stained with rose bengal, and also that it stained well with the rose bengal instead of fluorescence. Any underlying cause should be treatment. Basically, we use topical lubricants to treat the dry eye, and for the filaments, very important is an acetylcysteine. So the N-acetylcysteine is given to remove the filaments. Topical medication should be changed if a toxic effect is suspected and unpreserved preparation used where possible. Mechanical removal of filaments give short-term symptomatic relief. I've told you that we can remove with a forceps if there is a persistent corneal foreign body sensation and a patient is very complaining. Mucolytics such as 5% or 10% acetylcysteine drops, NSAID anti-inflammatory drops, for example diclofenac, hypertonic saline 5% drops 4 times daily, ointment at one time may encourage adhesion of the loose epithelium. Bandage contact lens may protect the cornea from shearing action of the lid. So basically what the 5% hypotonic saline is doing is, because the epithelium is loose and it is not very well attached to the underlying basement membrane, so the corneal epi is a hypertonic saline makes the corneal edema, water out of the cornea, so what will cornea dry and the epithelium will become attached to the basement membrane, so the it causes the adhesion of the loose epithelium. Recurrent corneal epithelial erosions. So recurrent is basically there are corneal epithelial erosions that are recurrent. It is mostly present in a case of a corneal dystrophies. It is the symptoms that is present in the case of corneal dystrophy. Recurrent corneal epithelial erosion is caused by an abnormal weak attachment between the basal cell of the corneal epithelium and the basement membrane. Minor trauma such as eyelid cornea interaction during sleep such as sufficient to precipitate detachment. Erosion may be associated with previous trauma or rarely corneal surgery and with some corneal dystrophies. So what happened is, because the corneal epithelium is very loose to the underlying basement membrane, so it become detached and it causes the with the minor trauma it causes the erosion of the cornea. Internal intervals between episodes can be very variable, even the same patient, but may occur in spades over a short period. Diagnosis. Diagnosis is severe pain, photophobia, redness, blepharospasm, and watering typically waken the patient during the night or are present on awakening in the morning. Basically, it happens during night when the eye is closed. It causes erosions, and patient complain of severe pain on waking up. Severe pain, photophobia, redness, and there will be the frequent blinking of the eye. There is usually but not invariably prior history of corneal abrasion, sometimes years previously, which may have been a minor compared with the recurrent symptoms. So patient usually present with recurrence of these symptoms. Patient present again and again with this kinds of complaints. So you always have to think about the recurrent corneal erosion syndrome. Signs are that an epithelial defect may be present by the time the patient is examined, as healing can often be very rapid course, but the extent of the loose epithelium may be highlighted by the areas of pooling of fluorescence and rapid tear film breakup. Infiltrate should not be present, though grayish slot and rolled epithelium may sometimes be reminiscent of this. So sometimes you patient present to you, but the patient there is no such type of epithelial defect on it, but it can be present, and what you can do is you can see the loose epithelium and you can see the fluorescent will pool around it. So let's see figure 7.40. Recurrent corneal erosion syndrome showing epithelial defect stained with fluorescent. There may be no signs of abnormality once a defect has been healed, but signs of epithelial basement membrane disturbance such as microcyst, punctate, or linear fingerprint opacities are often present. So these are all often present with the case of a corneal dystrophies. There can be the microcyst present on the epithelium. There can be a linear deposit. There can be the fingerprints like deposits on the cornea. They will be typically be bilateral in a stromal dystrophy and unilateral if the injury is the cause. So how will you treat it? Acute symptoms is treated with antibiotic ointment 4 times daily and cyclopentolate 1% twice daily. So if the patient is coming acutely, we give antibiotic ointment to prevent any secondary infection. Pressure patching should not be used as it may impair healing and does not improve comfort. In severe cases, a bandage contact lens alleviate pain but may not improve healing. Antibiotic drops rather than ointment should be used. Debridement of the heaped, scrolled area of epithelium with a sterile cellulose sponge or cotton tip applicator may improve comfort and allow healing from the edge of the defect. So these are just a kind of a symptomatic treatment what we can perform in case of the recurrent corneal erosion. Topical diclofenac 0.1% reduces pain. Topical Anesthetic dramatically relieves pain but should not be dispensed for patient use. Hypertonic sodium chloride 5% drops 4 times daily. An ointment at bedtime may improve epithelial adhesion. So I have told you the mechanism of this in the previous topic. Following resolution, some authorities advise using a prophylactic topical lubricant such as carbomer gel 3 or 4 times daily for the several months. So basically, you have to lubricate the eye. In a case of recurrent epithelial erosion, you have to lubricate the eye, and you have to make the eye wet so that such type of things do not occur. So, if the patient is having a recurrent symptoms, topical lubricant gel or ointment or hypertonic saline ointment instilled at bedtime used long term may be sufficient. A combination of oral doxycycline and topical steroid may be helpful. Both have shown to inhibit metalloproteinase inhibitor. Um, Important to disease pathogenesis. Long term extended wear bandage contact lens. So what we can use, we can give a ointment, antibiotic ointment and hypertonic saline ointment at the bedtime for the longer period of time in case of the recurrent symptoms. Long-term simple debridement of the epithelium in involved area, which may be followed by the smoothing of the Bowman's layer with the diamond burr or excimer layer. Most patients treated with excimer keratectomy do not get recurrences and the side effects are minimal. So you excise the area, and it can also have a good effect on the recurrent epithelial erosion. Anterior stromal puncture for localized area of the visual axis. It may not be necessary to remove the epithelium to facilitate this. So anterior stromal puncture is that you puncture the stroma, means you put the needle and you punch the stroma of the cornea, but off the visual axis, because if you do it on the visual axis, it may cause the disturbance of the vision. So xerophthalmia. So xerophthalmia is basically is a disease of the eye due to the vitamin A deficiency. Xerophthalmia introduction. Vitamin A is essential for the maintenance of the body epithelial surface, for immune function, and for the synthesis of the retinal photoreceptor protein. So it is very important in the synthesis of the photoreceptor protein, vitamin A. Xerophthalmia refers to the spectrum of ocular disease caused by the inadequate vitamin E intake and is a late manifestations of the severe deficiency. So basically, if a patient present with xerophthalmia, it means that he has been chronically and has been deficient of vitamin A. Lack of vitamin A in the diet may be caused by malnutrition, malabsorption, chronic alcoholism, or by highly selective dieting. The risk is in fact is increased if the mothers are malnourished and by coexisting diarrhea or measles. So what are the diagnoses? A World Health Organization grading system is set out in the table 7.7. So these are the World Health uh, Organization grading of xerophthalmia. So you have XN 1, 2, 3, S and F. ठीक है? N 1, 2, 3, S, F. So for N is like X, N is night blindness. So you can see first there is a conjunctival involvement. First there will be the symptoms, and then there will be the signs. So symptoms is there will be the night blindness. Then it will involve the conjunctiva. When the conjunctiva is involved, it is called conjunctival xerosis, which is X1A. And when there will be the bited spot with the conjunctival xerosis, it will be the X1B. Then there will be cornea will be involved. This will be the corneal xerosis. Corneal X3 will be the corneal ulceration. If less than 1/3 is involved, it is X3A, and if more than 1/3 is involved, it is X3B. Next is S is for scarring, corneal scar, and F is for xerophthalmic fundus. So symptoms are night blindness, nyctalopia. Patient complain of decreased vision at night. He cannot see at the dark. Discomfort and loss of vision. Conjunctiva. So xerosis is characterized of the dryness of the conjunctiva in the interpalpebral zone. So basically xerosis means dryness. Dryness. Xerosis is characterized by the dryness of the conjunctiva in the interpalpebral zone with the loss of the goblet cells, squamous metaplasia, and keratinization. Bited spots are the triangular patch. So this is a bited spot. This is a bited spot. It is of a foamy keratinized epithelium. Foamy keratinized epithelium in the interpalpebral zone thought to be caused of the corneobacterium cirrhosis. So cornea, what are the signs of the cornea? Cornea become lusterless appearance due to secondary cirrhosis. Bilateral punctate corneal epithelial erosion in the interpalpebral zone can progress to epithelial defect but are reversible with treatment. Keratinization, uh, sterile corneal melting by liquefactive necrosis, keratomalacia, uh, which may lead to perforation. So it is the cornea become first xerosed, mean dry eye symptoms will signs will be seen, and when there will be the corneal ulceration, it will be the X3. Retinopathy, characterized by the yellowish peripheral dots, may occur in advanced cases and associated with decreased electroretinogram amplitude. So decreased ERG will also be the signs of the vitamin A deficiency. Treatment is keratomalacia. What is keratomalacia? We have always also discussed it, that it is basically a melting by liquefactive necrosis. Keratomalacia is an indicator of a very severe vitamin A deficiency and should be treated as medical emergency due to risk of death, particularly in infants. Systemic treatment involves oral oil-based 200,000 IU or intramuscular aqueous-based 100,000 IU vitamin A for keratomalacia. Multivitamin supplements and dietary sources of vitamin A are also administered. Local treatment include consist of intense lubrication, topical retinoid acid, and management of perforation. So basically, you have to give the patient what is deficient. So you have to give the vitamin A to the patient, and locally, because of there is a dryness, we can give lubricants and we can give retinoic acid for the treatment. So that's it for the cornea part 15. We will see you in the next lecture.